Have you ever had like a physical symptom that you felt had a completely simple straight line cause?
Oh, right, like cause and effect.
Exactly. I mean,
Oh.
think about it. You scrape your knee, it bleeds, you put a bandage on it. Or, you get a headache, you take a pain reliever, it goes away.
Yeah, we really like it when our biology behaves like a simple math equation.
We really do. It's comforting. We want our medical issues to be visible, linear, and easily categorized because, well, it gives us a sense of control over our own bodies.
Completely. I mean, it is entirely human to want a straightforward answer to a problem. But the trouble really begins when the underlying architecture of an issue is incredibly complex. But the medical advice you are getting is still treating it like a scraped knee.
Right. And that is exactly where we are going today.
Hmm.
Like, what happens when common medical wisdom completely misdiagnoses the root of your problem?
It happens a lot more than people realize.
Yeah, and today we are looking at a really widespread issue that is constantly brushed off by society, and often by doctors, honestly, as just a simple lack of moisture.
Right, we're talking about vaginal dryness and burning.
Yes, particularly as women age, or transition through menopause, or face certain dermatological conditions. For those of you listening who have dealt with this, the standard advice is almost always just this dismissive, well, go buy some lotion or use more lubricant.
Which is incredibly frustrating.
Mm.
It is heavily underreported by patients. It's vastly underestimated in how it destroys your quality of life. And it's far too frequently dismissed with that, just use some lube mentality.
I mean, it minimizes a profound biomechanical shift down to, like, a minor inconvenience.
Exactly.
So to get to the bottom of this, we are pulling from a massive stack of clinical guidelines for this deep dive. I'm talking the heavy hitters.
Yeah.
We have data from the British Association of Dermatologists, the British Society of Sexual Medicine, the American Urological Association, and the National Institute for Health and Care Excellence.
Which is widely known as NICE.
Right. And nice. So we are looking at the foundational clinical guidance that represents a global consensus on genitourinary health.
And these sources are crucial because they give us the evidence to look past those superficial symptoms and examine what is actually happening to the tissue itself.
Which brings us to our mission for this deep dive. We're going to answer a highly specific but absolutely game-changing question for anyone dealing with this pain.
And it's a big one.
It is. Can structural introital narrowing, which is caused by advanced age or tissue layout changes, actually accelerate the localized friction and burning that we typically just blame on simple dryness? Okay, let's unpack this.
Yeah, so to really understand why friction and burning happen in this area, we first have to fundamentally redefine the problem for you, the listener. We have to look at how the physical landscape of the vagina and the vulva literally changes shape.
Like a physical architectural change.
Exactly. We have to move the blame away from just a surface-level dryness and look at the actual architecture of the tissue.
Right, and I get that estrogen is a key hormone in all of this, but I'm struggling to see the mechanical link. How does a hormonal drop translate to the literal shrinking of physical architecture?
Well, let's introduce genitourinary syndrome of menopause, or GSM.
Okay.
This is a condition that affects up to 80% of women. Historically, you'd hear it called vulvovaginal atrophy, but GSM is a much more accurate term.
Because it covers more than just atrophy, right?
Exactly. It encompasses a whole spectrum of structural and urinary issues. It is triggered by a drop in estrogen, usually around menopause, but it can also happen postpartum, during breastfeeding, or from breast cancer treatments like aromatase inhibitors.
Got it.
And when that estrogen drops, the entire cellular environment just completely shifts.
Okay, let's slow down and look at those cells. What is the first thing that goes?
The surface layer. The vaginal lining actually loses its superficial epithelial cells.
The outer barrier.
Yeah. Think of a highly estrogenized, healthy vagina. In that state, these superficial cells turn over incredibly fast. They shed every few hours.
Oh, wow, that fast.
Yes. This rapid, continuous turnover keeps the tissue thick, robust, and heavily shielded. But when estrogen plummets, the production of those cells diminishes drastically.
So the shield is basically gone.
Sometimes they end up making up less than 10% of the cell population. And they are replaced by peribosal cells, which simply do not have those same thick, protective qualities.
Okay, that makes sense. The surface layer gets thin and delicate because the tough cells aren't repopulating. But a thin surface doesn't really explain the whole area physically shrinking and narrowing.
Right. For that, we have to go deeper.
What is happening underneath that surface layer?
So beneath that surface epithelium is the lamina propria. This is the connective tissue. And this layer is packed with fibroblasts.
Fibroblasts.
Yes, think of them as the biological factories responsible for producing collagen and elastin. Estrogen basically acts as the on switch for these
Oh,
factories.
I see where this is going.
Yeah, without estrogen in the system, those fibroblasts basically go to sleep. They become dormant fibrocytes.
And collagen and elastin are the exact proteins that make our skin stretchy, bouncy, and resilient.
Exactly.
So if the factory shuts down, the tissue's going to change completely.
It fundamentally degrades. Without fresh collagen being produced to maintain flexibility, the remaining collagen fibers in the tissue undergo a process called hyalinization.
Hyalinization, that sounds intense.
It is. They fuse together, they become glassy, stiff, and really rigid. The tissue physically loses its elasticity. It loses its natural folds, which are called vaginal rugae.
So it's flattening out and stiffening up.
Exactly. Because of this rigid fusion, the labia minora actually resorb, meaning they shrink and recede into the surrounding tissue. The vaginal canal foreshortens and narrows.
Wow.
And crucially for our discussion on friction, the introitus, which is the vaginal opening, retracts and narrows. This specific structural bottleneck is called introital stenosis.
Okay, let's try an analogy to visualize this, because introital stenosis is a pretty heavy medical term.
Go for it.
Imagine a really nice, supple leather shoe, a perfect size 8. Over time, if you leave that shoe out in the baking sun and the leather dries out completely, it doesn't just get dry to the touch, right? The leather itself gets brittle, it loses all its stretch, and the shoe physically shrinks.
That's a great way to picture it.
And if you try to force a size 8 foot into that now brittle, unyielding size 6 shoe, you are going to get massive friction. You're going to cause severe damage to the shoe and the foot.
Absolutely.
So I have to ask, if the tissue is physically shrinking, fusing together, and turning into this rigid, brittle structure, isn't applying a basic over-the-counter lubricant just putting a Band-Aid on a structural blockade?
That is spot on.
Because if the leather shoe has shrunk 2 sizes and turned to stone, greasing up the foot doesn't solve the fact that the shoe has physically changed shape.
That is a highly accurate mechanical way to visualize the blockade. A Band-Aid is exactly what temporary moisture is in this scenario. And we see similar, sometimes even more extreme structural changes with dermatological conditions that our sources highlight.
All right, specifically lichen sclerosis, or LS. I noticed the guidelines spend a significant amount of time on LS.
They do. It's a major factor.
It's described as an inflammatory dermatosis. And it doesn't just dry the skin out, it radically alters the architecture. Kind of similar to GSM, but through a totally different mechanism.
Exactly. LS causes pale, atrophic areas, usually in a figure of 8 pattern around the vulva and perianal area. In severe cases, the fusion of the labia can completely narrow the introitus.
Just totally close it off.
Yes. It can even seal the clitoral hood entirely over the clitoris, burying it under a layer of skin. Because LS is an intense scarring process, this fusion creates a rigid, inflexible barrier. What's fascinating here is that whether the primary cause is the estrogen depletion of genitourinary syndrome of menopause or the inflammatory scarring of lichen sclerosis, the end result is mechanically identical.
That is wild.
The loss of collagen and the fusion of tissue fundamentally changes the mechanics of the area.
And understanding that structural bottleneck is the only way to understand the biomechanics of the friction itself. Because the opening is now narrower and the skin is incredibly fragile, any dynamic friction is going to cause trauma.
Right, the tissue just can't handle the force anymore.
And when we say dynamic friction in this context, I feel like the first thing people think of is sexual intercourse, the clinical term for which is dyspareunia when it's painful. But this friction isn't just about sex, is it?
Not at all. The clinical guidelines highlight that friction on this narrowed, unyielding opening leads to damage during everyday activities.
Like what?
Sitting at a desk in tight pants, riding a bicycle, the chafing of athletic wear during a run. The tissue is subjected to shearing forces it can no longer withstand.
So what does that damage actually look like on a clinical level? When someone goes to the doctor, what are they seeing?
You see petechia, which are tiny pinpoint blood spots under the skin from broken capillaries that literally burst under the pressure. You see fissures, which are literal painful tears or splits in the skin, often localized at the posterior fourchette. That's the very back of the vaginal opening. And you frequently see postcoital bleeding.
That sounds terrifying for the patient.
It is. The tissue is tearing because it no longer has the elastic capacity to stretch around whatever is causing the friction.
It sounds absolutely agonizing, and this is where the body's own defense mechanisms start working against the patient, right?
Exactly.
Because our bodies are incredibly smart reactive systems. When something hurts us repeatedly, we react. If I accidentally touch a hot stove, my muscles instinctively yank my arm away before my brain even fully processes the
A
burn.
withdrawal reflex, yes.
So what happens to the muscular system around a tearing, narrowed vaginal opening?
If we connect this to the bigger picture, we have to look directly at the pelvic floor muscles. When a woman experiences this painful friction and microscopic tearing, the pelvic floor muscles react protectively.
They tighten up.
Yes, they tighten. This is an involuntary subconscious guarding response.
They are bracing for impact, trying to shut the door to prevent further injury.
That guarding response is totally natural, but over time, those muscles stay clamped down, leading to pelvic floor hypertonia or levator antispasms.
So they just forget how to relax.
The muscles basically forget how to relax, and this creates a devastating vicious cycle for the patient.
Break that cycle down for me.
Okay, so the structural narrowing and lack of elasticity causes pain and tearing during friction. The pelvic floor muscles clamp down to protect that torn tissue. That muscle clamping makes the vaginal opening even tighter than the original narrowing.
Oh man, so it's compounding the issue.
Exactly. So the next time there is friction, the bottleneck is worse, the tearing is worse, and the pain is amplified.
And I imagine the anticipation of pain alone can trigger the muscle spasms before any physical contact even occurs.
Absolutely. The brain anticipates the pain and fires the muscles defensively.
But this presents a massive dilemma. If the body's natural defense mechanism is actively making the friction worse, how do you break the cycle? You can't just tell a muscle to stop protecting a torn tissue. You can't just think your way out of a severe muscle spasm when the underlying tissue is still brittle and tearing.
No, you cannot simply will it away, which is why the clinical guidelines are so adamant about treating the underlying structure and the muscular response simultaneously, rather than just masking the symptom with a topical slickness.
You have to fix the foundation.
You have to rehabilitate the tissue from the inside out.
Okay, so let's talk about how to actually break this bottleneck. The sources do mention lubricants and moisturizers, specifically citing products like YSVM, which is a vaginal moisturizer, alongside water-based lubricants.
It is really vital to distinguish between the two for anyone managing these conditions.
Right, they aren't the same thing.
Lubricants are used purely at the time of sexual activity to reduce immediate dynamic friction. Moisturizers, on the other hand, are used regularly, independent of sexual activity, to alter the fluid content of the epithelium and attempt to lower the vaginal pH.
And a quick but critical side note from the sources for anyone listening.
Yeah.
If you are using latex condoms to prevent pregnancy or STIs, avoid oil-based lubricants at all costs.
Yes, very important.
The oil breaks down the latex on contact, leading to condom failure. But back to the main point. These moisturizers and water-based lubricants might offer temporary relief, but they don't restore the physiology right. They do not wake up those dormant fibroblasts.
No, they don't. To actually rebuild the tissue, medical restoration requires waking up the fibroblasts so they start manufacturing collagen and elastin again.
How do we do that?
According to the guidelines, this is typically done with topical, localized estrogen therapies like creams, pessaries, or vaginal rings. Alternatively, there is DHEA, also known as progesterone, which is a precursor hormone. The vaginal cells absorb the DHEA and actually convert it into intracellular estrogen and testosterone locally.
We should definitely clarify for the listener, this is not systemic hormone replacement therapy that circulates through your whole bloodstream.
No, not at all.
This is localized therapy, applied right at the site of the problem, meaning the systemic absorption into the rest of the body is incredibly minimal.
Exactly. It stays where it's needed.
And applying these hormones locally helps thicken the epithelium, increases blood flow, and gets that crucial collagen production going again. It makes the tissue significantly less fragile.
It restores the biological scaffolding.
But wait, that only solves the fragility and the tissue quality. Hormones don't necessarily stretch out the structural narrowing that has already set in.
No, they don't.
And a cream certainly doesn't stop those pelvic floor muscle spasms we just talked about. So here's where it gets really interesting. The clinical guidelines don't just talk about chemical treatments. They recommend something that operates almost like physical therapy for the vagina. It's called vaginal dilator therapy. What exactly does that entail?
Vaginal dilators are smooth, graduated cylinders made of medical-grade silicone or plastic. They come in progressive sizes, starting very small and slowly increasing in diameter.
Okay.
The therapy involves using these dilators to gently and very gradually stretch the narrowed tissue over weeks and months.
So you are literally stretching the shrunken leather of the shoe back out, slowly and methodically.
That's it. You are improving the physical flexibility of the tissue, expanding that narrowed introitus. But more importantly, you are retraining the nervous system and the pelvic floor
You're
muscle.
teaching them to relax.
Exactly. By inserting a dilator at a highly controlled, slow pace, entirely under the patient's control and strictly avoiding any pain, the brain actually learns that penetration does not have to equal trauma.
I imagine it requires extreme patience and pacing. If you rush it or use a size that's too big, you cause pain. And the second you cause pain, those levator antimuscles clamp down again, and you're thrown right back into the vicious cycle of muscle spasms.
Yes, you have to adapt the tissue without provoking the body's alarm bells.
That makes total sense.
It desensitizes the nerve endings. It helps the pelvic floor muscles learn how to yield again instead of guarding. When you combine localized estrogen to strengthen the tissue with dilator therapy to physically expand it, you break both the structural bottleneck and the muscular guarding.
It is a slow, careful, highly intentional process. Tissue rehabilitation takes real time.
It really does.
But we live in a society that is completely obsessed with the quick fix. We want a 15-minute outpatient procedure that solves years of complex biomechanical degradation.
Which is incredibly dangerous.
Yeah, and when people look for a rapid solution of vaginal narrowing and dryness, they often stumble into treatments that can cause catastrophic, irreversible damage.
Which brings us to a very critical, heavily cautioned section of our source material. We need to discuss transvaginal laser therapy.
Hang on, I need to make sure I'm reading these guidelines right, because this part genuinely shocked me.
It is shocking.
The FDA in the United States and NICE in the UK have issued explicit, severe warnings against using CO2 lasers for what the medical wellness industry likes to call vaginal rejuvenation.
Yes.
If the underlying problem is that the tissue is paper-thin, frail, lacks blood flow, and is already causing a burning sensation from basic friction, why would anyone, let alone a medical professional, think applying a high-powered thermal laser to literally burn the vaginal wall is a good idea? Isn't that just throwing gasoline on a fire?
This raises an important question. Why is a multi-million-dollar industry pushing aggressive, unregulated thermal devices on delicate atrophic tissues instead of utilizing evidence-based hormonal and physical therapies?
Right. What is the logic?
Well, the theory marketed behind these lasers is neocollagenesis.
Okay, what does that mean?
The idea is that by causing a controlled thermal injury, essentially microburns in the vaginal wall, you will force the body's natural healing response to rush in, produce collagen to heal the wound, and thereby thicken and tighten the tissue.
But there is a massive flaw in that logic when dealing with GSM or LS.
A huge flaw.
In a healthy, highly estrogenized environment, a thermal injury might heal predictably. But in an estrogen-depleted, poorly vascularized, atrosic environment, the tissue simply does not have the biological resources or the collagen factories to heal properly.
Exactly. It lacks the scaffolding. Instead of regenerating healthy, flexible tissue, the thermal burn creates dense and flexible scar tissue.
The NICE guidelines shared some truly horrifying case studies of women who sought these quick fixes, and we really need to talk about them.
Do.
Let's look at case 1, a 65-year-old breast cancer survivor. Because of her cancer, she couldn't take systemic estrogen, so she was dealing with severe dryness and moderate vaginal stenosis, that narrowing we've been discussing. She underwent 3 consecutive laser treatments.
Right, and she resumed intercourse a few weeks later and suffered heavy, immediate vaginal bleeding.
From the laser treatment.
Yes. An examination under anesthesia revealed 2 massive vaginal wall lacerations.
Wow. But the long-term fallout is even worse. Months later, she presented with severe pain and an absolute inability to engage in intercourse. Her vaginal canal had foreshortened to just 2.5 centimeters.
That is tragic.
For context, 2.5 centimeters is barely an inch. That is a catastrophic loss of depth.
The thermal trauma caused the fragile tissue to scar and fuse together, a process called adhesive agglutination. The fibrotic scar tissue essentially glued the walls of her vagina together.
That is just awful.
The laser treatment, which was marketed to cure her narrowing, permanently worsened it.
And she wasn't an isolated incident. Look at case 3 from the NICE overview. A 68-year-old woman who had persistent and worsening pain after 3 laser treatments. On examination, doctors found a crescent-shaped fibrous band right in the middle of her vagina.
A permanent stricture.
Right. The laser had created a partial obstruction, a literal stricture.
Hmm.
Her dryness, her burning, her pain, everything got exponentially worse because she now had a thick band of scar tissue impinging on the vaginal canal.
These cases perfectly illustrate the mechanical danger. You cannot bully fragile atrophic tissue into submission with a laser.
No, you can't.
When you apply thermal trauma to a structure that is already shrinking and brittle, you risk replacing a reversible, hormonally driven narrowing with a permanent fibrotic scar tissue narrowing.
So the quick fix becomes a permanent structural nightmare.
Exactly. One that requires intense physical therapy and dilation just to regain basic, pain-free daily function.
It really emphasizes how delicate and deeply complex this biomechanical system is. It is not just a tube that needs to be tightened or lubricated.
Yeah.
It is a dynamic, living architecture of collagen, muscle, and hormones.
The structure dictates the function. When the cellular building blocks disappear, the structure shrinks. And when the structure shrinks, the function becomes painful.
Right. So to briefly recap what we've unpacked today. The friction and burning associated with the genitourinary syndrome of menopause and conditions like lichen sclerosis are not just about a simple lack of moisture.
Not at all.
They are heavily driven by a physical loss of architecture, the hyalinization of collagen, the physical narrowing of the introitus, and those secondary, highly protective pelvic floor muscle spasms.
The evidence proves, definitively, that telling a patient to just use some lube is a vast, potentially harmful oversimplification of a complex biomechanical issue. It ignores the reality of the tissue.
So what does this all mean? It means if you are dealing with this, you have to advocate for yourself. You have to respect the mechanics of your own body and treat the root structural cause with localized hormones and physical dilation, rather than just applying a superficial Band-Aid while the foundation crumbles. But before we wrap up this deep dive, I want to leave you with one final provocative thought. A new thread to pull on, built right from the source material we've been discussing. We talked earlier about how the loss of estrogen stops the shedding of those superficial cells.
Yes, the epithelial cells.
Right. Well, those superficial cells are rich in glycogen. Without that glycogen being continuously shed into the vaginal canal, the healthy lactobacilli bacteria, which feed on glycogen, starve and die off.
And that causes the vaginal pH to rise from a healthy, protective acidic level to above 5.0,
Exactly.
which allows hostile pathogens like E. coli to thrive.
Right. So consider this. What if this drastic shift in the localized microbiome, the state of dysbiosis, directly irritates the localized sensory nerves in the vulva and vagina?
Oh, that introduces the concept of the sensory nerve illusion.
Exactly. What if the brain is perceiving a low-grade, constant, invisible bacterial inflammation as the physical sensation of friction and burning?
That is a fascinating angle.
What if the pain you feel isn't just the physical tearing from the structural narrowing? What if it is a neurological alarm bell triggered by a fundamentally altered chemical environment?
It implies that the nerves themselves are misfiring because their microscopic ecosystem has been polluted by the pH shift. The burning isn't just mechanical friction, it's chemical irritation being translated by the brain as structural pain.
It is definitely something to think about the next time we assume a physical sensation has a purely physical cause. As we said at the start of this deep dive, we like our medical diagnoses to be linear, cause and effect.
But biology rarely is.
Right. Sometimes the proverbial X-ray machine doesn't just show a simple broken bone. Sometimes it shows an entire landscape that has shifted, where the structure, the muscles, and the microscopic bacteria are all conspiring to create a perfect storm.
A perfect storm indeed.
Keep questioning the common wisdom, because the real answer is usually hiding in the architecture.